everyone, and thanks for joining us so much for this edition of the ACTnet Asia Pacific Regional TB Journal Club. We've got a really great session planned today. My name's Harry Walker. I'm an ID physician and microbiologist. Today I'm in Melbourne on Wurundjeri country, and I'd pay respect to Wurundjeri elders and indeed all Aboriginal and Torres Strait Islander elders in all the different Aboriginal countries we're on today. Today I'll be facilitating with Gail Cross, and I'll just hand over to Gail to present our speaker.
Hi, everyone. Thanks for coming today. We've done a few of these and they've been very successful, and I'm particularly excited about today's session. So I'm Gail. I'm an ID physician. I work here in Melbourne at Monash at Burnett Institute, and I do clinical research in tuberculosis as well. So I'm very excited about today because we've got Tasnim. Tasnim is an infectious disease and gen med physician who's based in Western Sydney. She has worked incredibly in many very interesting workplaces and has had a really interesting career path. She worked for MSF. She's worked in remote Australia. And when she was in MSF, she really looked after a lot of people with multi-drug resistant tuberculosis, as well as with extensively drug resistant tuberculosis. So I think there are very few people in the country who would know how to manage XDR-TB, and Tasnim happens to be one of them. And in fact, she contributed to the WHO guidelines on the management of MDR and rifampicin-resistant tuberculosis, which was published in 2022. And she's currently a postdoc in Greg Fox's group in Sydney. So very excited to have Tasnim. And she is going to talk to us about a recent Lancet infectious disease publication, and I'll hand over to her.
Thanks, Gail. Thanks for the very generous introduction. I should mention that I treated XDR-TB before it was bedaquiline-resistant. So it was back in those days, it was fluoroquinolone and a second-line injectable resistant, whereas modern-day XDR-TB is bedaquiline-resistant. Which is another kettle of fish. But you can see my screen, can't you? Okay, so I'll get going. So before I get into the paper, I always like to talk a little bit about the history of tuberculosis. I only have one screen, so if anyone needs to stop, just scream out and I'll stop talking and I'll see what's happening. All right, so yeah, I always like to start with a little bit of history because I think it's really important in understanding what MDR-TB is today and XDR-TB is today, and also the way that treatment has cycled and evolved in that time period. So as a lot of us may know, the history of TB is quite old. And there's an article which is on your screen, the title which is on your screen, which was published actually quite a long time ago now, but is probably one of my favorite articles. It's about 50 pages long, but it details every single randomized control trial that was conducted between 1946 and 1986 in the world of TB. And as you may be aware, TB was actually where the first randomized control trials were ever performed, and it was comparing streptomycin to bed rest, and this was in the 1940s. And then through the 40s, you had drugs such as streptomycin and para-aminosalicylic acid. But as some of you, if any of you have used PAS, you'd know that it's highly emetogenic and is one of those drugs that when patients even look at the tablet, they can feel quite nauseous. And then in the 50s, we had isoniazid and rifampicin come through. And all of these, again, a lot of these drugs were introduced into TB regimes through randomized control trials. And in the mid-50s, there was a 3-drug regime that was established. And then it was finally in the 1970s when a 4-drug the current HRZD combination was established and has been used since then. And then, of course, money in tuberculosis went away, and there were no trials for many decades until more recently, where people, and in that time, people were more interested in heart disease and cancer, which is also important. So rifampicin was really the game changer in the world of TB. If you look through the history of all those trials, it was only when rifampicin was introduced that the duration of TB treatment could be reduced, and rifampicin reduced duration to about 6 months. And a lot of the initial trials would show that a single drug combination resulted in high rates of relapse, and it also demonstrated that shorter regime durations resulted in relapse. So a lot of the durations tended to be 12 to 18 months until you had more and more effective drugs, and especially with rifampicin, where it was cut down to about 6 months. But as early as these trials were being conducted, resistance became a problem, and it was documented from the early days as well. The first real outbreak described of drug-resistant tuberculosis, so in this situation, MDR-TB, which is resistant to isoniazid, actually in this case it was isoniazid, streptomycin, and PAZ, was an outbreak in New York, where 23 members of a household in New York were all diagnosed with resistant TB, and several of the members died, and a lot of them were treated with extended drug regimes. But yeah, it's an ESHRE article if you're interested. And in terms of WHO guidelines, the early guidelines came out for resistant TB. The early treatment schedule, some of you may be familiar with these sort of boxes that they've had in the initial guidelines, where they would recommend treatment based on class of drugs. So in the initial guidelines, it was the injectables, the fluoroquinolones, and then other agents. So, and other agents initially were clofazimine, linezolid. And again, the reason this is important is because then the reason a lot of these agents were put into these tables were because they were the ones that were used in the 40s and 50s and 60s to treat drug-susceptible TB. So they were known to be effective anti-tuberculosis drugs, and therefore they were being reintroduced to treat drug-resistant TB, and again, it was being used for prolonged durations because short durations were not as effective. But a lot of the evidence that drove the initial WHO guidelines were actually based on observational data. There was not many randomized control trials as there were in the early days. And then the study sort of slowly trickled in the last 20 years. The first was the study by Armin van Duren, who died, I think it was last year. He was one of those people who were very dedicated to tuberculosis from the Netherlands, but he did the Bangladesh regime, where he treated a number, where their group treated a number of people with drug-resistant MDR-TB, so resistant to isoniazid and rifampicin, with a short course regime. So in selected patients, they demonstrated, so highly selected patients, so they couldn't have fluoroquinolone resistance or other resistance, and they would be treated with a cocktail of drugs, which included 6 months of aminoglycoside injectable, and this regime demonstrated a reduction, was non-inferior to the longer regimes for highly selected patients. But the main issue with the regime was that it was highly toxic with the aminoglycoside, and the other issue with this regime was that it was a very, very high pill burden, and there was often quite a lot of dropout and loss to follow-up, which is really true with just about any MDR-TB regime. So bedaquiline was the first TB drug that was developed in 40 years, and it was developed or released by Johnson & Johnson in 2012. And some of you may be aware that bedaquiline, it was used for in many different in MDR-TB in many different contexts, and was slowly being shown to be effective. And even after the 10-year patent expired with Johnson & Johnson, they sort of refused to reduce the price of bedaquiline, which became a big point of contention with Johnson & Johnson, with a lot of programs that treat TB, because it really, bedaquiline has been, like rifampicin, a game changer in TB treatment in terms of being able to reduce the duration of MDR-TB treatment. And one of the key the National TB Program of South Africa was one of the first countries to take up bedaquiline within its program. And in 2018, they subbed in bedaquiline they subbed in the aminoglycoside with bedaquiline into the short course regime, the 9-month short course regime from the Bangladesh regime. And they also showed that their short course all oral regime had good outcomes. And this sort of was the trigger to then also do further studies. So in 2022, there were 3 studies, or 2020 and 2022, there were 3 studies that were published, which demonstrated that a 6 to 9 month course of bedaquiline, along with protamidate, another new drug, linezolid, and plus or minus moxifloxacin, did have were non-inferior to the longer regimes used. So TB Practical was conducted in Uzbekistan, Belarus, and South Africa by MSF, and Nix and Xenix were conducted in South Africa and a few other settings as well. And these 3 studies really were the game changer, the initial game changer in being able to drive the 2022 WHO guidelines, which then endorsed the 6-month BPALM regime as part of treatment for MDR-TB. And this was really very important in being able to reduce the duration of TB treatment from 24 months to 6, from 12 to 24 months, or 9 to 24 months to 6 months. Of course, it's not as glorious as it seems, because bedaquiline, protamidate, and even linezolid is quite expensive, not always accessible, and there are many settings around the world where it's not easily available. But it is, however, still a remarkable achievement that we're able to have a 6-month regime for MDR-TB now. And the 2025 guidelines, which came out earlier this year, also reaffirmed the use of shorter regimes for MDR-TB, but there are now newer options available, and this is thanks to some further studies that have been conducted, and there are more studies in the pipeline as well, but the ones that have been used in 2025 include the BEAT-TB trial in South Africa and the NTB trial in multiple settings. Which use various combinations of bedaquiline and delaminid-based regimes. All right, so just briefly about MDR-TB. That was a whirlwind and very abridged version and cursory version of the history of TB, and there's a lot of details that I've left out, but MDR-TB causes there's about 400,000 cases of MDR-TB per year, and the cure has increased from 50% to about 68%, and that's 2021 figures. More recent figures are still not widely available. However, there's still 15% mortality. Settings which use BPALM seem to suggest that the cure rate may be much higher, closer to 80%. There are 58 national TB programs which recommend the 6-month BPAL regime. Of course, a lot of that is still also affected by access to the drugs within the regime. And most importantly, the South Africa has been using bedaquiline since 2018, and it also since recently, so not I think in the last 3 or 4 years, has recommended replacing moxifloxacin with levofloxacin because it's more available in the South African context. So there should be some data available for levofloxacin use in the BPAL regime as well. So what is bedaquiline? It's a diarylquinolone antimicrobacterial drug. It inhibits the mycobacterial ATP synthase, which is used for energy production, and it's metabolized by CYP3A4, so it does interact with drugs like rifampicin, but it doesn't have the problems of drug interactions that rifampicin does. It has a very, very long half-life, so it's loaded at 200 milligrams daily for 2 weeks, and then 200 milligrams 3 times a week. And the most common adverse events is that it prolongs QTC, which is a concern because in the BPALM regime, you also have moxifloxacin, which can prolong the QTC, and it can cause hepatitis as well. And there is data now to use it in children, pregnant women, and during breastfeeding, but there's limited data in end-stage renal failure, but there are still case studies of using it and case series using it in end-stage renal failure and dialysis, so it is being used. Bedaquiline resistance. So as with any drug, as soon as you introduce it, you get resistance. So the most common methods of resistance is through certain genes. So the ATPE, which is a transmembrane protein for the ATP synthase, can be one way that there is mutations in the ATP is one way that can cause resistance, and this can increase the MIC quite significantly. The more common one that we usually see is the RV0678. And the reason this one is more common is because it can also cause, so the use of clofazimine can also increase the risk of mutations through RV0678, which means that if there's previous exposure to clofazimine, there is a much higher risk of bedaquiline resistance. And then there are a number of other genes as well. Okay, and so resistance can acquire, like any drug, can be before, during, or after treatment. Clofazimine is one of the big risk factors for bedaquiline resistance because clofazimine is used much more commonly and is much more available than bedaquiline. And also the long elimination half-life contributes to the resistance as well. So most of the data suggests that the prevalence of resistance is between 0 and 10%. In the South African context, there's quite a lot of evidence that the resistance of bedaquiline, since they have been using it since 2018, is closer to that 10% mark. But there's also studies coming out of Mozambique and China that have, and Central Asia, that have shown that resistance may be, between 2 and 6 or 7%. So it's not negligible at all. Okay, and so at the moment, WHO recommends for bedaquiline-resistant tuberculosis the use of a individualized longer regime, which can include combinations of probably not bedaquiline, but one of the uses combinations of from the table of WHO from drugs such as delaminid, meropenem, and clofazimine and linezolid. Probably not clofazimine and bedaquiline. I think I pasted the wrong table, sorry. Okay, so I think I took too long going through the background. But anyway, so now we're coming to the article. So treatment outcomes of bedaquiline-resistant tuberculosis. This is a Lancet Infectious Diseases article, and I go through it in detail. Okay, so the aim of this study was to describe the management strategies and the treatment outcomes of patients with bedaquiline-resistant pulmonary tuberculosis in South Africa. And South Africa is an important context because it is also a high HIV burden setting. It was a retrospective case control study, and it matched cases of rifampicin-resistant to matched cases of bedaquiline resistance one by one. So everyone had MDR-TB, and it was bedaquiline resistance and not bedaquiline resistant one by one matched. It was in an area called East London in South Africa, and the inclusion criteria was 13 years or older with culture confirmed tuberculosis. So they had to have culture confirmed TB, pulmonary TB, and the resistance to bedaquiline had to be confirmed by phenotypic DST, and that was performed by midget with the MIC cutoff of about 1 for resistance. And then the controls, so the matched controls also had to have culture confirmed TB and susceptible to bedaquiline. They actually picked the controls from a SWIFT trial, so that they were conducting in another study. And the bedaquiline-resistant cases came through a certain clinic, so a referral clinic, which were referred more complicated cases of TB. And the study time period was between January 2018 and January 2023. Exclusion was only where there was inadequate available information about the treatment, and the follow-up time was until treatment completion, or 18 months follow-up time, or the study endpoint, which was January 25, whichever was the latest for the individual patient. The outcomes that were measured was time to sputum culture conversion, and the way that was measured was by having two sputum samples that were negative, and they could be they had to be consecutive, but didn't have to be consecutive by month, and it had to be within 12 months from treatment initiation. And they used WHO treatment outcome definitions for unfavourable outcomes, and measured the portion of unfavourable outcomes. And then they also measured the tuberculosis-free survival at 18 months. And the statistical analysis was using Cox proportional hazard. The Cox proportional hazards for time to sustain culture conversion was calculated, and the variables that were used were age, sex, BMI, HIV, antiretroviral status, CD4 counts, baseline microscopy positivity, and previous treatment for rifampicin resistance. And then they also performed a logistical regression. Okay, so results. I'm very much a text person, not a pictorial person, so I only have the text tables. But if anyone would like to see the picture, the graphical tables, the graphical presentations, I'm happy to show them at the end, which I have within the slides, but I've hidden them because I'm not smart enough to understand them. So there were 82 patients in the bedaquiline-resistant group and 82 patients in the bedaquiline-susceptible group, and the median age was about 37, 38, and the smear was positive in about 50 to 70%, and the baseline smear status. So most of them had lower burden disease. So 44% or 28% had no AFP positive, and then 25 was just one smear positive. 70% were HIV positive, with viral load detectable in quite a high portion, actually. So it was 68% in the bedaquiline-resistant group and 93% in the bedaquiline-susceptible group. So that's an important point that will come up later, in the sense that there were quite a lot of people with detectable HIV viral loads, suggesting that they had were immunosuppressed. In the bedaquiline susceptible group, there were no previously treated TB episodes, and that's also important because having previous TB episodes does increase your risk of poorer outcomes, but I guess it also increases your risk of bedaquiline resistance. And the reason for that is because the matched group was chosen from a SWIFT TB trial that they're conducting. So and that was one of the exclusion criteria in that trial. All right, and just in the bedaquiline-resistant group, there were quite a large number of people, so more than 70%, almost 80%, who were treated with bedaquiline or clofazimine. All right, so the overall drug susceptibility results. 85% had resistant to bedaquiline and fluoroquinolone resistance, and so the resistance was tested at baseline. So and some people had it available before the index sputum as well because of previous treatment results. And then it was tested at baseline and after the index sputum. And then one of the important things to note in here is that there were 7 individuals who developed linezolid resistance during the treatment. So 2 of 77 had resistance at baseline, and then 7 of 33 had developed linezolid resistance. But other resistances, some of them developed, but nothing to point out at this stage. All right, so bedaquiline resistant wasn't always confirmed at the diagnosis. It was often confirmed later. So if we look back to this table, hold on. Because the time for the bedaquiline-resistant, so the time for the bedaquiline-resistant result to be available was not always at the time of diagnosis. So the resistance data was not always available until about a medium of about 4 months after, which makes sense because I guess you first have to culture the TB, then you have to do the first line resistance, and then when you suspect resistant, then you set up the bedaquiline resistance. So a lot of the bedaquiline diagnosis was not confirmed until quite late into the treatment. And the reason that's important is because a lot of the patients you'll see when we come to the treatment regimes were actually treated with bedaquiline-based regimes. At that time, once the bedaquiline resistance was confirmed, treatment modification occurred in 26 of the 44 patients, sustained culture conversion was reached in 57% at the time bedaquiline. So some of the patients already had culture conversion and didn't require any modification, but those who didn't, some of them did end up having treatment modification and some of them didn't. So a lot of the treatment modification decisions were left to clinician discretion. So the treatment duration after the index sputum, the median treatment duration was 17.7 months, and bedaquiline was used in 72 of 82 patients, as was continued in 68% of the patients. So even after the bedaquiline resistance was confirmed, it was continued in 68%. And a lot of the reasons that it was continued was because of culture conversion. The duration of bedaquiline was approximately 5.5 months. And I guess the reason for that is because earlier WHO and availability of bedaquiline meant that guidelines recommended a maximum duration of bedaquiline of 6 months. And this study was conducted from 2018 to 2025. So a lot of them would have been earlier on when bedaquiline was used for 6 months or less. But the range did vary from 4 days to 13.5 months. Okay, so the most common regimes, so these are the drugs used in most regimes, in most patients. Bedaquiline used in 88%, clofazimine used in almost all patients, linezolid is used in almost all patients, and delaminid used in about 75%, levofloxacin in about 65%, and meropenem, I guess, is the important one because that's one of the ones that are recommended in bedaquiline resistant, but it was started in about 32 patients, so about 39%, and started at a median of 156 days after index sputum was collected. And I guess the reason that it's low is because a lot of patients had already achieved culture conversion or were lost to follow-up. All right, so in terms of outcomes, so this is just for the bedaquiline resistant arm. And we're looking at outcomes at 6 months, 12 months, and 18 months after index sputum collection. Successful outcomes were achieved in about 52% at 18 months. About 23% died. I'm only talking about the 18 months now. 23% died, which is quite a large portion of the cohort. 10% of them had died by 6 months. Again, that you have to factor into the treatment decisions and the changes in regimes. At the end of 18 months, there was still 18% who are still continuing to receive TB treatment. So their treatment had been prolonged, obviously, because they still didn't have evidence of having treatment and a successful treatment outcome. Sorry, one more thing is to note that there were 43% who were tuberculosis free, but in care. I can't remember what that came from. I might have to go back and look at that number. Okay, so the median time to sputum culture conversion was 175 days in the bedaquiline resistant cohort and 32 days in the bedaquiline susceptible cohort. So there's quite a significant difference between those two arms. And the median time to the first negative, so sustained sputum culture conversion is 2 sputum being negative, 2 sputa, but the median time to the first negative was about 100 days. And bedaquiline resistant was found to have be associated with a much longer time to sputum culture conversion. And that was even after adjusting for baseline microscopy and baseline fluoroquinolone resistance. So treatment outcomes within those with bedaquiline resistance were found to be unfavourable in 67% of patients, and there was treatment failure in about 43% of the patients, and this is at 18 months. I guess I've gone through some of this anyway. So 23% had died and 79 was still on treatment. Okay, so just to go to the limitations of the study, I've talked about some of them as we've gone through. There were multiple drug resistance in the bedaquiline-resistant arm, so a lot of individuals with resistance to fluoroquinolones, clofazimine, and linezolid. There was a lot more advanced HIV in the bedaquiline-resistant arm, which may be why they had poorer outcomes. The extent of pulmonary disease was not available, so there was no radiological details available, and there was nothing about whether anyone had bilateral disease or cavitatory disease. As I mentioned, the matched controls had no previous TB treatment, and it's just a single treatment centre. And not only is it a single treatment centre, it is a referral centre that they were taking the bedaquiline-resistant cases from. It's a small sample size. And there was more bedaquiline treatment in the bedaquiline-resistant, more exposure to bedaquiline in the bedaquiline-resistant arm. And there was no consistency in the way that the sputum was collected. So in a trial, you'd normally collect it once a month. But in this situation, because it was a clinical observational study, there was no clear guideline of when the sputum was collected. So some had it monthly, some had it every second month, or some had it sporadically. And the timing of treatment initiation was also unreliably documented because it was retrospectively reviewed through the notes. So the timing of treatment initiation was not always available. All the statistics were actually based on the timing of index sputum. And bedaquiline testing was only available to those with poor treatment outcomes. So as I said, it took 4.5 months to get the bedaquiline resistance results, and that is partly because it takes some time before you actually get prompted to do bedaquiline resistance testing. And the study period does not include a time where the BPAL regime was already implemented in the South African NTP. So once that's introduced, as it is now, it's likely that we'll have much higher bedaquiline resistance in certain settings, especially in South Africa, which has been using bedaquiline for a long time. But the main implications is even with those limitations, I think it's quite evident that bedaquiline-resistant TB has very poor treatment outcomes, and that you require very long treatment durations for bedaquiline resistance. And given the significant delay in diagnosing bedaquiline resistance, there really is a need to have more rapid molecular testing available for bedaquiline resistance, such as within, like a GeneXpert cartridge or something like that, to be able to diagnose resistance in a more timely manner, and maybe institute meropenem earlier or more effective treatment earlier. And then there's a long delay between index sputum collection and treatment initiation, which may and that delay can contribute to community transmission, meaning that there can be treatment-naive people who end up with bedaquiline resistance, which is a significant concern for the community. I think that's all I have. Yes, that's it. Okay, so I think we still have quite a lot of time for discussion.
Thanks so much, Tasnim, for taking us through that paper. There's a lot there. I think first there's a couple of questions from Sadid. I might start with maybe some methodological questions.
Yep.
Do you think this is a well-conducted study? And if
No. I think I pointed to that, but yeah, sorry, finish your question.
Yeah, not complete. I mean, and then I suppose I didn't see anywhere in the paper a 1 or 2 line, like one of those little summaries, these are the conclusions or these are the lessons. If you were to write a 1 or 2 sentence, these are the 2 takeaways or lessons from this paper, what do you think there might be? What did you take away from this paper?
I think I took away that bedaquiline resistance does have poorer treatment outcomes, even though it was a poorly conducted study. I think the numbers are hard to ignore. I think it definitely does demonstrate that bedaquiline resistance has poor treatment outcomes. So I think that's one. And I think the second thing is having more timely diagnosis of bedaquiline resistance would be the other thing, because there's such a huge delay in diagnosing bedaquiline resistance, which may be a reason why that there's poorer outcomes, because some of the patients just continued bedaquiline because they had already been halfway through their treatment and had some degree of response. But we don't know if they go on to have relapses or if after they finish treatment, what happens to them after that.
Yeah. Sidit, would you like to ask your question?
Yes, happy to. Thanks for that great presentation, Tasnim. One of the things I was like the table that you showed of the bedaquiline-resistant cohort, and 80% having previously been exposed to bedaquiline. I forget what's on that, but other antimicrobials that would typically be part of an MDR regimen. Yeah. I get the sense that it's a cohort of patients that's probably had previous treatments with an MDR regimen, and for whatever reason has failed or progressed or developed bedaquiline resistance. That to me implies, is this cohort of patients that they've included in this bedaquiline, are they inherently different to what they've tried to control for? Like, are these patients failing for other reasons? Are they advanced HIV with CD4 counts that are really low? Are there compliance issues? Are there other factors that are not accounted for, given this is a retrospective study, that might be contributing to the poorer treatment outcomes? Or are there any factors that are known, like, for this particular patient, if you give them BPARM, their chances of successful outcome are much less compared to another cohort? Are there is that known, or any opinions from your perspective?
I mean, BPARM it's recommended not to give BPARM for patients who have had bedaquiline exposure, and it's also recommended to consider not to give it if they've had prolonged clofazimine exposure as well, because of resistance. But that's just the BPARM aspect of your question. But I think in terms of the patient population that was selected, yes, absolutely. I think they selected a population that were, I think one of the things that's written in the paper is that it is a referral center. So it's difficult to know if there are other people who have had bedaquiline resistance outside of the referral center who have had better outcomes. So it's definitely possible that they were only referred the patients with advanced HIV and with, poorly, that were less likely to be adherent to their treatment, or they had other, social, psychological factors that contributed to poorer treatment outcomes. That's why they were referred to the referral center. So absolutely, the selection of patients were definitely highly biased and definitely contribute to the poorer outcomes in the bedaquiline-resistant cohort. But I guess in the absence of larger studies or data, that this is sort of one of the smallest studies that we have that's available in terms of treating bedaquiline resistance. And I guess from a microbiological sense, it does kind of make sense that you would fail treatment if you had bedaquiline resistance. But it's also possible there's bedaquiline resistant patients who got better that we just don't know.
Yeah. I think one of the things, I'm going to play devil's advocate. I actually don't think this was a badly conducted study. I think that, the fact that it was a single center is problematic. The fact that they had such high levels of HIV and that they had obviously detectable viremia is also a concern, right? So you're talking about, but it was matched, equally balanced across both groups. So what this retrospective match cohort study is really saying, that in this difficult to treat patient population anyway, right? You've got ongoing HIV viremic disease, they failed treatment in the past, is that if they get bedaquiline resistance, they're stuffed. There's such high rates of non-sputum culture conversion, or even if they do sputum culture convert, you really need to keep them on the drug in order to prevent them from relapsing, or they have treatment failure, or they die. So I think it's a very select group of patients, and the problem with XDR-TB, and it may not be a problem for long, which is a problem in itself, is that you can't conduct a randomized controlled trial because you would take forever to recruit into the trial. So actually conducting a proper, as opposed to retrospective propensity matched cohort study, to do a randomized controlled trial, it would cost too much and take too long, but that may not be a problem for long. But one thing I wanted to point out, which I came across this morning and I alluded to before, was that there's another paper that's come out in the last 2 weeks, Lancet, one of the other Lancet publications, I can't remember what it was, but I can circulate it to the group, is essentially, it was from the, which group was it? The European groups, Christopher Lang et al. And what they looked at was also retrospective and what are the treatment outcomes in the group who have XDR TB. So it's a mixture of bedaquiline resistance, but also linezolid resistance, and they had double the number of cases as this paper did, so about 160 or 150 cases altogether. And they had 20% who died, 37% who had treatment failure, 13% who had lost to follow-up, and they only had treatment success in 40%. So I think what's interesting here is that you've got these two recently published retrospective cohort studies that have got very similar outcomes in terms of having bedaquiline resistance, which we know we're going to increasingly see, and we have to be prepared for what you remember the days of what it looked like when we had MDR TB and we didn't have bedaquiline. That's what we're looking at in terms of having that same group of patients who are extremely hard to treat without the right drugs to treat them. Yeah.
I might just address some activity in the chat.
Yeah.
There was some activity about, in response to Sadid's earlier question about whether these patients had exposure to the BPAL-M regimen specifically. And I think you mentioned that, Tasnim, at the end, that they hadn't, that this cohort is before BPAL-M was implemented in South Africa. So they were having other MDR regimens.
I think BPAL-M, or in South Africa, they use levofloxacin. And I think BPAL-L was implemented in South Africa in 2022 or 3, I think it was. So it was, so the Nix and Xenix studies were published, and TB Practical was 2022, and I think they implemented it. They were pretty quick, but 2023, so only a couple of years that they've had it. And I don't know if implementing it into the NTP means that everyone is able to access the regime, because implementing it into an NTP and actually providing it to everyone, is not always the same. But South Africa is quite efficient, so it's possible that everyone does receive it. But yeah, I don't know.
One of the challenges I know from not so much from Xenix and Nix, but from Stream 2 and from TB Practical, was that the standard of care had changed. So people were already on bedaquiline and they wanted to randomize to a bedaquiline arm. But regardless, they were able to show that if you received BPAM, you certainly had much better outcomes compared to the standard of care, even if that standard of care contained bedaquiline in some instances, because that had become, over time, without necessarily the trial data to support it, they had introduced bedaquiline already because they needed something. Otherwise, patients were dying.
So Abby has a question. Were there specific reasons why BPAL was not recommended for patients with CNS osteoarticular-miliary MDR TB? It was really just because if you look at the Nix, Xenix, and TB Practical studies, they only included pulmonary TB. I'm not sure if one of them included, I'd have to go back and look to see if one of them included extrapulmonary TB, but none of them included extensive TB. So none of them included CNS, osteoarticular, or miliary TB, and that's why they're an exclusion criteria. But it is recommended by WHO for all other forms of extrapulmonary TB other than extensive pulmonary disease.
Another.
Helen Cox has added that. Access to BPAL-L is now good in South Africa.
Yeah.
Quite essential.
I would suspect that it is, because South African NTP is really quite efficient. I just don't know enough about what's happening now to say that with confidence.
I'd also like to know from anyone in the group whether they have seen in their various places that they work, whether they have seen bedaquiline resistance or XDR cases. We were just discussing before the Journal Club started that actually we ourselves haven't seen it. I haven't seen it here at Monash. I don't think Harry has seen it at the Royal Melbourne. And Tasnim, I think you had one case, or you remember?
We had a few cases in Uzbekistan, yes, yeah.
So,
I mean, we get a smattering of cases of Southern African TB, but the vast majority of Australian TB is associated with Asia, isn't it? So,
I wonder though whether it is something that we will see, because bedaquiline is increasingly becoming, even in drug susceptible TB, the rifampicin alternate, right? If someone's not tolerating rif,
Yes, yes.
etc., we're going to bedaquiline. The access is increasing, so I wonder if we will start seeing it. And I think your point, Tasnim, of whether the expert cartridges need to also include mutations against RV0678, which is the most common mutation associated with the bedaquiline, may be the only way that we'd be able to get, find patients with this problem and put them on treatment or alternative treatment quickly.
Yeah. I mean, a lot of inclusion into cartridges is always an economic decision, so it won't be included until it's economically viable to include it. So,
but this was a lot of the laboratory aspects of this, and not so much the clinical aspects, were discussed at the union last year. And I believe these mutations in the gene are at various positions throughout the gene, and it didn't look suitable for a PCR method. Right. But there is a lot of push for Illumina's really making targeted next generation sequencing more available. And I anticipate that's going to have to fill this gap. Yeah. Direct on specimen, targeted, amplify the gene and then sequence. Yeah.
But you'd also need these. So I don't know how available Illumina would be in the more research, in the more resource limited settings. And that's sort of the settings where you would need it to be able to detect it earlier, because it's not just sufficient that you have a well-equipped lab that can diagnose it. And that's why it's easier if it's available in a gene cartridge, because most settings now have access to expert, whereas they don't have access to other forms of diagnosis.
Yeah, it would be really interesting to know this year's union about the South African laboratory team, because they were doing so much work, all people throughout South Africa on it. And I wonder now what their algorithm in the lab is, because I presume it's not test rifampicin, get rifampicin resistance, then start testing other things, then test bedaquiline. Well, even by last year, the algorithm used to be only test bedaquiline if rifampicin and fluoroquinolone's resistant. And they showed last year that clearly that is not a good approach, because there's a lot of bedaquiline resistance when quinolones are still susceptible. And then I presume now it's cut it shorter to test bedaquiline further up front, and then sequence. They obviously can't sequence all of them in Southern Africa. It's so many isolates, but sequence the relevant ones a bit earlier as well, perhaps.
Andy has asked, now that we're moving to whole genome sequencing for routine susceptibility testing, that is in Australia.
Yes, in Australia, yes, we will.
Will we pick up bedaquiline resistance earlier?
Yeah.
Yes, I mean, I think in Australia, yes, we will be able to. But...
Well, interestingly, one of the findings from that other paper I mentioned, which talked about treatment outcomes from XDR-TB, that the highlight statement, outcome statement from that paper was the odds ratio of having treatment success between, whether you did or didn't have XDR resistance. The odds of having successful treatment if you had an XDR resistance pattern was a lot higher if you were in a high income country. And I think it's exactly because of this, is because our diagnostic capacities are a lot higher, access to drugs a lot higher, our ability to have programmatic engagement in care of patients is infinitely better than they do in very resource limited settings. So it's really interesting to see that we may not have, there are no better drugs, right? We probably all have access to the same thing, but the importance of really being able to follow people up and support them in other ways as well. So I did want to ask though, to Tasnim, as well as Harry and anyone else in the audience, if you do come across a case of bedaquiline resistance, what are you going to do? What are you going to use? How are you going to manage it in Australia, at least?
An individualized long regime, I guess. Probably you'd want, I guess in Australia, you would presume you'd have whole genome sequencing, so you'd be able to identify all the or most of the resistance that is possibly available. So you'd be able to pick out 5 drugs based on that. And I think you something like a carbapenem, linezolid, if you can use it. The barrier to linezolid resistance seems to be a lot higher. So, hopefully you could still use linezolid, cycloserine, clofazimine. I think you'd have access to enough drugs. If you have whole genome sequences, I think you could find 5 or 6 effective drugs. And then you'd probably have to go a bit longer. So, something for 18 months and then drop a couple of drugs after a few months if they're going well. I don't know, Harry, do you have any?
Well, my similar, but the question that's still open to me that we're talking about is should these patients still receive bedaquiline?
Yeah.
And one of the findings in this paper is that associated patients receiving bedaquiline seem to do better. It's obviously observational data, but I think if it's one of the ATPE mutations, then no, I probably wouldn't use bedaquiline because I'd expect that it's properly resistant. But in mycobacteria in general, the term resistance just always makes me think, what do we mean by resistance? What do we mean? It's not as clear. It's not, and we're using a multi-regimes. Like normally with the normal bacterial infection, you'd say resistance is you use a standard dose of that drug and it doesn't work well enough. People fail. But when you're using 4 drugs at once, that definition doesn't really hold. And then even the in vitro data with these RV0678 mutations, it seems to increase MIC, from 1 or less to 2 to 8. Well, so it's still active. It's active in vitro and it's probably active in the patient in a usable way.
Harry, sorry, you go, Tasnim.
Oh, sorry. No, what I was going to say is, one of the things the paper does state is that it is a referral centre. So there's quite likely a lot of other bedaquiline-resistant cases that were treated and had a successful outcome that just weren't referred. And they probably did get bedaquiline-based regime. So it is a very good question as to whether or not you would just use bedaquiline. Because there probably are patients who are just receiving bedaquiline and they do have bedaquiline resistance, but we just don't know, and they are getting better.
So I think if I had, it would obviously depend on the extent of disease and location, and it would depend on immune status of the patient. But let's say immune competent and not extensive disease, and it was susceptible to linezolid and let's say quinolones as well, then I think I'd use BPAL-M with lots of closer monitoring and probably add another drug. And then really base the decision a bit more on clinical progress and clinical failure. Now, that is in the Australian context where we can monitor these people, because then there's the public health hat, isn't there? That you don't want this sort of TB to be spreading, and you want to be sure that they're culture converting, and you want to be sure that they're supported all the way through treatment. But I wouldn't write off bedaquiline, basically. I'd probably use bedaquiline, at least in the initial phase, to treat.
Fair enough, Yeah.
One thing you brought up a point which I think is really interesting, and I don't know from the microbiology perspective whether it'll move to this, but checkerboard testing and sensi-titer testing. I know there was a sensi-titer plate created by Thermo Fisher where you were able to really look at drug combinations in order to work out whether someone was, whether the bug was or wasn't responding to the combination. Because obviously there's synergism and there's antagonism of drugs, and we discount all of that when we test these drugs in, unilaterally in silos, as it were. But the other thing, I wanted to bring everyone's attention to this trial by a Korean group, which was published in Lancet ID in 2022. The trial was called MDR-END, and it was, why it caught my attention was because they used a bedaquiline-free regimen, and it was a combination of delaminid, linezolid, levofloxacin, and pyrazinamide for a duration of 9 months. So, and that showed good outcomes in the MDR-TB group. Obviously, they didn't have linezolid resistance, so this was specifically for bedaquiline-resistant patients. And it's one of the few trials that we've got of people who with bedaquiline, who have MDR-TB and where they opted to use a bedaquiline-free regimen. So I think that that's something we should really consider. Instead of the cobbled together combination of drugs. And the reason that I'm not in favor of that is only because of how toxic we know they are and how long we have to continue the treatment for. And I think if we could try and be person-centered, I wonder if really we need to get our hands on Delaminid and have it ready to go for that first patient that will show up on our shores with bedaquiline resistance.
But why Delaminid and not Pretominid?
Well, no, that's an excellent question. Why not, right? I'm just saying that that's what the trial showed. But of course, we could be using Pretominid instead.
I think there's some evidence that Pretominid is a better drug than Delaminid as well. I understand it's coming from a study, but yeah, I guess it's...
And we've got it, right? So there's a few questions here.
Kira's just asked how reliable is bedaquiline susceptibility testing or the WHO catalogue? I had a bit of a look through. It doesn't look, I couldn't find any TB reference laboratory directors on this call. In terms of reliability, so what I can say is that these mutations, RV0678 mutants, are described with bedaquiline testing at or below the critical concentration. In other words, phenotypically susceptible using the current WHO cutoff. So implying that the testing with the current critical concentration doesn't fully detect the genotype. Is the catalogue of mutations, I mean, the catalogue of mutations relates to the phenotypic result. It's not mutations directly back to clinical. Where possible, they talk about it, but it's the genotype is validated back to the phenotype, at least currently.
I mean, that's always a question with genotype as to how well does a genotype reflect the phenotype.
And
I mean, what we really want is the genotype to predict clinical outcome irrespective of the phenotype, and that would imply that it's a better test.
But I remember in the early days of when RV0678 was first described, and we just weren't seeing the same phenotypic resistance as Harry's just said, but increasingly so now. Phenotypic resistance, it's quite clear that you may need another mutation in addition to RV067, but certainly it seems to be a surrogate marker of developing or emerging resistance to bedaquiline. So to be wary of that. Yes, exactly right. And Andy has pointed out as well that the reason is because bedaquiline has got such a long
half-life. Yeah,
thank you. So
there was interesting data. It's not just a long half-life. I remember it's the large volume of distribution that someone had an animal model last year at the Union showing that you generate the mutants in vivo at the start, at the build-up phase of bedaquiline rather than at the tail.
I got asked a very interesting question yesterday. Was that now that they've someone who's on BPAL and now that they're at the tail end, whether or not you continue for a bit longer because of the long half-life with bedaquiline. But I was thinking, maybe without bedaquiline as well, if the bedaquiline sticks around. But I've never come across that in the literature as to whether or not anyone's tested. Like I've never seen any data of anyone just continuing drugs because of the long half-life. But it makes sense, right?
But I think the trial for TB Practical was what 2 years or 18 months of follow-up, and they didn't.
Yes. No, they didn't. Yeah, that's right.
So I think I don't see us as necessarily having to do that.
No.
And wrap up. We're at 2 p.m. Thank you, Tasnim. That was excellent, and I really appreciate you taking the time to present. And thank you for everyone who was able to attend.